Hello, listeners. A warm welcome to Views on Health. And as yet another Monday evening comes by, it's a great pleasure to have with me on the program today Dr. Duleepa Baranage, consultant eye surgeon, National Hospital in Kandy. At the very outset, Doctor, a warm welcome to SLBC and thank you for finding the time to be with us, coming from Kandy to our studios at SLBC in Colombo to be a part of this program. Thank you so much.
Thank you. Thank you very much, Fatima, for inviting me in.
And as a consultant eye surgeon, Dr. Duleepa Baranage is going to focus on causes of blindness. Something that I think most of us wouldn't want to be affected by blindness. Nevertheless, it's reality that some people have lost their sight and some people are on the way to do so for health reasons, which is what our focus is on the program today. So may I invite you, Doctor, without any further ado, to tell us the causes of blindness, and also a question that I'd like to know, I think it'll be interesting for our listeners to know, is how common is this condition?
Yep.
Over to you.
Yeah, thanks a lot. Right, so, to start off, eye problems are pretty common, right? So, and also very life-changing as well. So people, whenever the eye is kind of affected, they rush to the doctor, are saying this is that. And probably the commonest problem would be the spectacle errors, right? Myopia or hyperopia, mainly myopia, that is, short-sightedness. And then, of course, that can be, of course, rectified by spectacles alone. But there are few causes which actually can hamper your eyesight or your vision a lot more than just spectacle corrections. So if you take the worldwide statistics, the commonest cause for blindness, if you talk about blindness per se, which is probably the most dangerous cause one could of course think of. The most commonest cause for blindness would be cataracts. So everybody gets a cataract when they grow older, right? It's age related, and there are a few cataracts which are not age related, which which can happen before age as well. But still, cataracts is the most commonest cause of blindness worldwide. But the good thing with cataract is it's totally reversible. So the most commonest reversible blindness worldwide, of course, is again cataracts. Then if you go to number 2, it's glaucoma. This is worldwide, and of course it's true for in the Sri Lankan context as well. So but glaucoma is a silent killer, right? So glaucoma is irreversible. The blindness caused by glaucoma is irreversible. So the commonest irreversible cause of blindness would be glaucoma. And of course, third varies, depends on the region. In developed countries is age-related macular degeneration, again an age-related problem. When you grow older, your macula degenerates, which can be treated, of course, with various modalities. But in Sri Lanka, in developing countries, the third most cause of blindness would be diabetes. So diabetic retinopathy, we have to talk about it in a lengthy way to get the awareness going on.
Thank you, Doctor. That's interesting. Can I ask you a question now? Obviously, it's age-related, and you said now if you take cataract, that a few people get it when they are younger as well.
Yeah.
Then glaucoma, as you say, is irreversible.
Yeah.
And then there's diabetes, which is rampant anyway
Yes.
in Sri Lanka.
Yes.
And it goes to the extent of affecting one's eyes.
Yes.
Now, although you said it's age-related, if you take diabetes, and you quite rightly said we should have a special focus on it, but at this point in time, just to ask you a question, there are so many young people affected
Yes.
Because of diabetes.
Yes.
So which means they are likely to get their sight affected?
Yes, of course. That's the problem, with especially after the post-COVID era, we call it. it's been, as you correctly said, rampant, out of control, because now the second and the third causes, glaucoma and diabetes, are silent killers, right? So when you realize that you're going blind, it's probably too late. So that's why proper evaluation, follow-ups are very necessary with glaucoma, and also more importantly with diabetes. All the diabetics, they tend to just get the drugs in, and not to go to an eye surgeon or a kidney specialist to get their kidneys checked, eye specialist to get their eyes checked, and they neglect it for such a long time. And then when they come saying that you can't see, that's probably a bit on the end stage, and we might not be able to get that vision back again. So that's why it is very important, especially the young. We see a lot. I have a subspecialty in vitreoretinal surgery. I'm a vitreoretinal surgeon apart from being an eye surgeon. So we do a lot of these diabetic retinopathy surgeries, and the trend is now very bad. All the young, early 40s, maybe early 50s, diabetics come with very, very, very hard eyes, very bad eyes, which are hardly recoverable. So, yeah.
Can you explain the term silent killer?
Yeah, good. Right. So, silent killer is, you will realize the disease once it has already killed your organ, right? So, glaucoma is probably the most silent killer, right? But diabetes is also a silent killer when it comes to the whole system. I think we'll be having a segment on diabetes separately, but just to brief you up, let's say if you get a heart attack, now you will realize once you get a heart attack only that diabetes has hit your heart. So which might be the end of the story. So likewise with the eyes, once it had bled into the eye only, you will realize that diabetes has hit your eye, which can be very, very hard to control afterwards. Yeah, so that's why I meant by the silent killer kind of pronoun. But yeah, so it just keeps on killing you, but you will realize it until it has already killed you.
Thank you. So as the name denotes,
Yes.
It's killing you within, you don't even know, and
Yes.
suddenly it erupts, and then it's too late. Is it to take treatment, or it can
Not
be...
really. It's never too late. It's never too late. But the prognosis, or the chances of you becoming normal again, right? Your eyesight becoming what it used to be, goes down with time. So that's why early treatment would warrant better outcomes.
So can we focus on cataract?
Yes. Yes, so cataract, as I said, it's a common problem everywhere. Once you grow old, you get cataracts. Everybody at some point of their life will get a cataract surgery done, right? Once you grow old. Now, let's say a 60-year-old walking about asking me whether she or he has a cataract, my answer would be simply yes, right? So everybody will have a cataract. Now, what the patient wants to know is whether it warrants a surgery. So that's the discussion we will be having with the patient. So yes, you will have a cataract, right? A 60-year-old seeing me will have, of course, a cataract. But whether he or she needs to get it operated is a different story. That depends on the individual. So as I told you, although it's the most commonest cause of blindness, it's totally reversible. We can do a surgery, get rid of the cataract, and put a lens in so that he will get the previous vision back without a glitch, right? So now question is when to get it done. Yes. So what I normally tell patients is to get it done as the first instance you feel uncomfortable. Now that depends on the patient. Now let's say now vision is not only about the reading vision, or you give a chart to read up far, you put lenses in outside, with spectacles, you could probably read the last row as well. But vision is a holistic thing, that's just the visual acuity where you can read black letters on a white board. But then, of course, it has lots of other components as well, like the brightness, the contrast sensitivity, the ability to, pick colors out of, a bunch of colors, the ability to cope up with light, the glare. Now, those also are affected in cataracts. Now, let's say what I normally tell patients is the first instance you feel uncomfortable, you feel that the cataract is ripe enough to be operated, right? the first thing you will realize is glare at night. Right? When driving at night, the headlight would be a bit too much for you to cope up with, right? So that's probably the first symptom of cataract you get, right? So let's say a person who drives at night a lot, a professional who requires more, pristine vision, a doctor, a teacher maybe, might actually get their cataracts done much earlier than the normal, person, where even though they have pristine visual acuity, they're hampered with their vision because of that other components not, aligning well with their day-to-day work. So they might actually get the cataract done at that stage. So in that case, yes, early cataract surgery for them will actually improve their quality of life. Then let's say they don't do it at that stage. The next step would be, even with the best of spectacles or best of spectacle corrections, you might not be able to read the whole board. One last line might go missing. 2 lines might go missing. 3 lines. That's how the aging process, with the age, the cataract, grows. And you can get it done anytime you want. So again, back to my first advice. The first instance you feel uncomfortable, you have to get it done. Why? Because the earlier we do the cataract, the less complicated it can be. Any surgery at any point can complicated. Now this I have to make the public aware of. We do maybe 100 cases, one will actually get complicated. We do 1,000 cases, one can actually go blind itself, right? But you have to do it when it's necessary. Let's say you walk on the road, you might meet up with an accident, but if you want bread, you have to walk on the road, right? Just because so it's like that, right? So we can't predict anything. But the first instance you feel uncomfortable, now it's when the cataract is early, right? It's easier for the surgeon to do the operation, and post-operative complications are also very less. So that's why we normally tend to do it a bit earlier than necessary. But again, you have to be symptomatic to get it done. Just because you have cataract doesn't warrant a surgery. The first instance you feel uncomfortable and you have to get it done. Again, earlier the better, because the more complicated, the more denser the cataract, the more complicated the surgery can be.
Thank you, Doctor, for that very detailed and lucid explanation. Just a question. Would it affect any passenger, any road user in the night? It's not necessarily the driver. One can be sitting in the car or whichever vehicle and then see the oncoming headlights, right? And then that can also affect even any person.
Yes.
So from to that extent, that is one of the first signs to look for, which is very easy, because if that glare of that headlight is going to affect your vision, even if you're a passenger, not necessarily a driver.
Yes, of course. Lots of, not everybody drives at night, right? So yes, even even you being a being a passenger, you can kind of gauge how your cataract is. And just because, as I told you, that's the first symptom you will get. So if you're not driving at night a lot, right? If you're just a passenger all the time, right? Then of course at that stage it might not warrant a surgery, right? Because with the spectacles you can move about in your day-to-day life without a glitch. But when it comes to a certain point that your day-to-day life is affected, that is the point you have to get it done. Yes, you can, what people tend to do is you can just postpone it. Okay, no, we still can cope up with it. It's hard to do my work, but still I can cope up with it, and keep on postponing it. Still we will do the surgery. You come at with a very very bad cataract where you can't see anything at all. Still we will be doing the surgery, but the complication profile rises with the density of the cataract. So earlier the better, but as late as necessary, something like that, right? Okay.
There's another question. Can it affect both eyes simultaneously, of one eye and then the other eye? Because we hear of people getting both eyes done within a period of time, within maybe a few months after getting the first eye done.
Yeah.
How come that both eyes get affected?
So as I told you, it's an aging process, right? There are a few cataracts which are not age-related, but most commonly it's the age-related cataract we see in the body. So of course you have 2 eyes, you're born with 2 eyes, both your eyes age together, right? So of course you will get, of course there will be probably most of the time when we see patients, they sometimes come up with the answers like, my right eye is worse than the left eye. Yes, there probably will be a harder cataract or a more mature cataract on one eye compared to the other. Yes, but when we do that eye, they will realize how bad the other eye is, right? So and again, yes, there's no specific time frame where you have to do the other cataract, or and there's no point in actually delaying the cataract. Also, what I normally say is you can do one eye today, you can do the other eye next day even, right? We don't generally do both eyes on the same day, unless of course there are specific indications for those, like if you have to give general anesthesia for these kind of surgeries. Yes, but then generally we do one eye on one day and the other eye on the next day, purely because just in case there are infections, as I told you, there are complications involved with the surgery. Just in case, if something gets complicated, the other eye might also get affected. Very rarely, but yes, so we normally try to do it on two separate settings, 2 separate days.
And just one more question, doctor, before we move on to glaucoma. Cataract is done under a local anesthetic, is it?
It's under topical anesthesia most commonly, right? Topical is we just put drops in, just like we put normal drops, so that the eye is anesthetized. You can feel you can hear, of course, whatever we say. You can feel the touch and all, but you will feel no pain. And then in specific cases, we inject a local anesthesia to numb the eye even further, so that the movements are also restricted. Where here you can move the eye. You just ask you to look at a light, and you just have to keep on looking at a light for 5-10 minutes, and the job is done. And then, of course, very rarely in very uncooperative patients who require very special attention, we can do it under general anesthesia. But generally, most of the time, maybe I would say maybe 95 or even more than that, 95% of the time, we do it under topical anesthesia. All the eye surgeons, yeah.
Thank you. Can you move on to glaucoma?
Yes. So again, regarding the cataract surgery also, there's nothing to fear about it. What we do is we remove your natural lens and then put a acrylic, let's say plastic, an acrylic lens into the eye, so that you will get your vision back. The common feature we do is we try to correct the distance vision as much as possible. For reading, probably you will have to use glasses, but then of course there are newer lenses where we can offset both far and near together. But of course those lenses are expensive, and some are very rarely custom made as well. But there are options. You go, if you have cataracts, and if you think you have cataracts, it's better to see an eye surgeon and get a detailed view on what to put, what to do, and what are the lenses available. And there are whole set of lenses which you can choose from. Yes, and of course, for the second commonest cause, glaucoma, cause of blindness. Glaucoma is irreversible. The commonest irreversible cause of blindness. So it's probably, if you want me to pick the most silent killer out of all the diseases, probably glaucoma. Because what happens in glaucoma is, now, what I normally tell patients also, now, if a human being lives for 350 years, they will anyway go blind, because your nerve dies with time, right? With age, the nerve dies. There's always a small, progressive vision loss or a small nerve fiber loss with aging. But you have to live for 350 years for that to experience, which nobody has ever done. So, right. But in glaucoma, what happens is you go blind by the time you're 60, 50 or 60 or 70. So the progression is much, much faster, right? So what happens in 350 will happen in around 60. So the rate of progression, or the rate of the nerve fiber loss, is much faster in glaucoma. And when you go blind, when 100% of your nerves are lost, whatever is lost is been, we can't recover it at all. What is been lost is lost. The danger in glaucoma is you will realize something is going wrong when around 95% of your nerves are gone, right? So what we do in glaucoma is, if we find a glaucoma patient, what we do is we lower the eye pressure, right? Why? That's why people talk about eye pressure. I have eye pressure, rather than glaucoma, they say I have eye pressure. Because what we do is, even if the pressures are normal, we lower down the eye pressure, so that, let's say you go blind at 60, we try to push it to 70 or 80 or 90. And if we push it to maybe 100, 110, that would be nice. We can't entirely stop it, but we postpone the inevitable, right? So what happens is now, as I told you, they will realize when 95% of their nerves are already gone. By the time they realize, patients realize that something is going wrong, when the vision, their acute vision is affected after 95% of your nerves. So then we only have 5% to play with. So we don't know, even with the best of drugs, best of treatment, we don't know how long we can maintain that 5%, because there's always a loss. We can only just can entirely stop it. We can't entirely stop it. We just can slower down the rate of progression. So we don't know that 5%. We don't know how long will it take to get that 5% off as well. So that's why it's very dangerous. So once you realize it is affecting your eyes, it might be a bit too late. So that's why glaucoma is generally diagnosed as an incidental finding. You come to change your specs, we see the eyes, we see changes in the eyes, we explain the patient, do some tests, diagnose glaucoma and start off treatment. Very rarely only patient comes saying that I'm blind now, what is wrong. And by that time, of course, it's probably a bit put too late to treat. So yeah.
So compared like cataract, where you can detect and you do surgery, glaucoma can set in earlier, where the age is concerned.
Yes and no. Now it's like this. Now cataract, as I told you, yes, even if you are late, we do the surgery, uncomplicated surgery, it totally reverses your vision. Let's say a blind person walks in with a cataract, we do the surgery. If there's nothing wrong in the back of the eye, just because the cataract he or she is having the visual impairment, it's totally reversible. They will get their vision back to what it was. But glaucoma, walk in with blindness, we can't reverse the blindness. We can only maintain what he or she already have, right? What she or he already has. So let's say they walk in with a slight impairment. We can't correct that impairment with treatment. We just can stop the progression of it being worse. So that's why glaucoma, as I told you, is a cause of irreversible blindness. So once you go blind, you are blind. So let's say you walk in, somebody walks in with a 70% nerve loss. That 70% already gone. I can't take that. I can't bring that 70% back. What I have to do is to maintain that 30% which he or she has. So that's why it is important. And then yes, we first treat medically. We put drops to lower the eye. The main treatment would be lowering the intraocular pressure. Right? So that's why people talk about eye pressure a lot. So the only treatment we can offer is to lower the pressure, even if the pressures are normal. Generally, we see a bit higher pressures in glaucoma, but even if it's normal, we put it down to a certain extent that, and then we of course do serial scans to see whether the nerve is still kind of deteriorating. So what we do is we start off, there are 4 types of drops. We start off with 1 drop, do analysis to see whether the nerve is still dying. If it's still dying, with 1 drop, we add another drop, So even after 4, even after maximum treatment, if still it is going down, then of course we have to go for surgery. There are surgical treatment available as well. There's a laser treatment option as well. It depends on the eye and the condition.
So doctor, but then if you're saying that if the drops don't work, you're going for surgery, that means there is hope to regain sight?
Regain is probably the bad word. To maintain what you have. To maintain what you have. Because there's no regaining of vision when it comes to glaucoma.
Okay.
Now, in a cataract, yes, you can regain your vision what you had, 20 years back or whatever, right? But glaucoma, we just have to work with what you have. We just maintain what you already have. There's no regaining of vision in glaucoma. That's why it's more dangerous.
So if it's sight for X percentage, you try to maintain that percentage of sight.
Exactly.
You can't get anything more than that. And you try to stop it going further.
That's correct. That's
interesting and also alarming. So Dr. I must say that it's been really, really enlightening to listen to your explanation on causes of blindness, focusing on cataract and glaucoma. Another aspect is diabetes, but perhaps we should focus on it entirely on another program so that you will be able to enlighten our listeners further into that into the situation where diabetes is concerned. Now, just one more question where glaucoma is concerned. If the nerves are affected, what brings about this condition?
Yeah. So right now we can't pinpoint on one single cause, right? There's no particular cause for this. Just like, still they are finding it difficult to find out how diabetes happened. Many problem, many co-founding factors like the genetics, your lifestyle habits, everything comes into play. But glaucoma is the same. You have it, you have it. You don't have it, you don't. We can't just predict someone having glaucoma. There is a genetic predisposition, yes, where there is a higher tendency to have glaucoma if your parents have glaucoma. If you're a diabetic, yes, the prevalence of glaucoma in diabetics is a bit higher than the normal population. So yeah, otherwise, that's another question patients always ask: what can we do, or what can the patient do to prevent the progression, or to slow down the progression, which we don't have any answer to, because there's nothing they can actually do to prevent. You can just, you have to live your normal life. There's nothing you have to change in your lifestyle. It just happens to be another disease with probably an idiopathic or no cause. But once you have a diagnosis, there are ways to kind of stunt the progression. So that's what is important.
Thank you, Dr. Time has caught up with us. What's your take-home message?
Yes, so eye reviews. Now, we'll talk about diabetes on another separate program, as you said. So glaucoma and cataracts. Cataracts, of course, you will realize on your own. Glaucoma, the best possible threshold would be, now everybody gets this disease of the 40s, right? You will not be able to read up close when you approach your 40s. So then, of course, people will tend to go to get their specs done. Always consult an eye surgeon if possible, right? Rather than just walking into one of the optometrists and getting the glasses done just for your convenience. Better to go check your eyes with a consultant. So every 40-year-old coming to see us, we will do a small checkup to see whether you have any other comorbidities, specifically glaucoma, right? So then, of course, we can just check and say, okay, you're all right. You don't need to kind of, be on follow-up. And of course, if your parents have glaucoma, family history of glaucoma, it's better to anyway get your eyes checked.
Thank you, Doctor. On that note of advice, we end this very interesting discussion on causes of blindness. To you, Dr. Duleepa Baranage, consultant eye surgeon, National Hospital in Kandy. Thank you so much for being with us on the program and sharing your expert knowledge on this very important topic. Thank you, Doctor.
Thank you very much. Thank you. See you next week. Yeah.
Thank you too to Prabha Veerasuriya for technical assistance. I'm Fatima Razi Kada saying good night and looking forward to your company next Monday, same time, when we'll have Dr. Duleepa Baranage back with us to focus on diabetes in the eye.